1 minute. Good evening, all of you, and good evening, all of you. Hope you're all doing good. All of you here. Hello, Rishraj, Siva Prasad, uh, Asas, and I hope you all are, doing good. And I hope you liked it, Siva Prasad, and Nanu, and everybody. So in today's session, there will be, we'll learn about CT scan, MRI, a bit of neuroradiology and respiratory radiology, four very important chapters. In the first part, we had covered about ultrasound and we did a lot of introduction and obstetric and gynec ultrasound. And in this video, we'll try to cover CT, MRI and the neuro as well as respiratory part, right? So let's get started, guys. So we'll first start with the CT scan. The screen sharing is happening. Okay. The first one, a CT scan. How do you differentiate a CT scan from an MRI? Remember, in CT scan, the bone, the cortical bone is white. The cortical bone is white on CT, right? The bone is white on CT scan. And the fat, the subcutaneous fat, the fat appears dark or hypodense. So if it is black, we call it hypodense. If it is white, we call it hyperdense on CT scan, right? And CT scan is basically based on linear attenuation of X-rays, right? So it's basically an X-ray procedure, linear attenuation of X-rays. And this is based on density of tissues. The attenuation is based on density. And how do you measure this linear attenuation? In Hounsfield unit. Hounsfield unit. And what is the Hounsfield unit of water? The reference value is water or fluid. How much is it? 0. And what is the Hounsfield unit of fat? That is minus 50 to minus 100, right? So these are important Hounsfield units to remember. So the reference Hounsfield unit is for water or fluid, that is about 0. Now, having done that, let us just come to some important images. Good evening, Chavan and Cortex. Let's come to this image. Now look at this, the bone is white, the fat is dark, right? So the subcutaneous fat you can see here is dark, but the bone is white. So these are CT scans. So this is a coronal section and this is an axial section. Look at the kidneys here, they are bilaterally enlarged kidneys, right? So you can see large kidneys. And in the kidneys, you are having this black area similar to the subcutaneous fat. So this is a fat containing lesion in the kidney. So whenever we have a fat containing lesion in the kidney, there is a fat containing lesion in the kidneys. How do you know it is fat containing? Please try to understand. How did we interpret that? First, we understood it is a CT scan image. The bones are white and the subcutaneous fat is black. Then we try to look at the kidneys. The kidneys appear enlarged. The kidneys are bilaterally enlarged and they show this black areas within, hypodense areas within, which are similar to subcutaneous fat. On the coronal section, on the axial section, they are appearing similar to the subcutaneous fat. So we consider them to be a fat containing lesion. A fat containing lesion in the kidney, what do you think is this? Do you know any fat containing lesion in the kidney? This is angiomyolipoma. Angiomyolipoma. And can you tell me, where do you see bilateral angiomyolipomas? Bilateral angiomyolipomas like this, in both the kidneys you have it, right? So bilateral angiomyolipomas is feature of tuberous sclerosis, right? The next lesion here. In this lesion here, this is a CT scan, and in the CT scan, you can see the bone is white, the subcutaneous fat is black. So it is a CT scan image, and in this CT scan image, if you see carefully, you are seeing these enhancing areas of the sulcal spaces, interhemispheric area. So what do you think is this study? Is it a plain study or a contrast study? It is a contrast study. Is it a contrast CT? Is it a CECT? Is it an intravascular contrast? No. If it was intravascular contrast, it would have been only in the vessels, right? It would have been in the cortical vessels, not in the sulcal spaces. If you see contrast in all the sulcal spaces, in the CSF spaces, sylvian fissure, interhemispheric areas, you are looking at a study called as CT cysternography. CT cysternography. We do a lumbar puncture, inject the contrast, right? We do a lumbar puncture and inject the contrast. So this is CT cysternography. This is done for CSF rhinorrhea, right? So this is done for CSF rhinorrhea. Do not confuse CCT from CT cysternography. CT cysternography, we do a lumbar puncture, inject the contrast into the subarachnoid space, into the thecal space, right? So this is CT cysternography done for CSF rhinorrhea. Next thing. Now look at here. Look at this image. The bones are white, and you can see there is a reconstruction done of the kidneys and the ureter, the pelvis and the pelvic calcium system is seen clearly. And what do you see? How many kidneys are you able to see here? How many pelvic calcium systems you are seeing? This is the right side, and on the left side you are able to see there is a duplication. So this is a CT urography image showing left-sided duplication, And can I ask you, from yesterday's class I taught you, can I ask you which ureter shows this adder head appearance or cobra head appearance, the ureterocele? This ureterocele is seen in which ureter? Can I ask you? Do we see it in, superior ureter or inferior ureter? In which ureter do you see this ureterocele? Is it seen in the superior ureter or inferior ureter? Adder head appearance or cobra head. We learned that rule, Weigert-Mayer rule in duplication system, right? So we learned SEMO, right? So it is the superior ureter. Very good. Superior ureter will show you this. Superior ureter will be inserting inferior-medially and is prone to obstruction in the form of ureterocele, right? So that is what we learned yesterday. So it is the superior ureter. If you trace, it is the superior ureter that shows this thing. If your bone is dark, the pelvic bones are dark, and the pelvic calcium system is seen, this condition is an MR urography. This technique is a MR urography technique where the bones are black. The bones are black and you are seeing the pelvic calcium system. This is MR urography. The urine itself acts as a contrast on a T2 weighted image. So MR urography can be done non-contrast T2 weighted also, right? Non-contrast T2 weighted also. The urine itself will act as a contrast. So in conditions who are having renal problems, where we cannot give a contrast CT, where you cannot give gadolinium, where we want to look at the pelvic calcium system without giving contrast, we can go for MR urography. By using a non-contrast T2 weighted image, you can reconstruct the pelvic calcium system and the ureter, right? So that is MR urography also. Now, look at this image. In this image, you can see the bone is densely white. So this is CT scan. So now we'll look at the CT anatomy of the brain. We'll look at chest, abdomen sequentially. So if you look at here, this is the outer gray matter. This is the white matter. These are the ventricles, right? The lateral ventricles. And here, what is this structures that I'm marking with the arrow here? Can you tell me what is the structure that I have marked with the arrow? These are your columns of the fornix, right? So they are the columns of the fornix. And this white matter that is joining the two frontal lobes, this is the genu of corpus callosum. And this white matter that is joining the two occipital lobes, this is the splenium of corpus callosum. So you should know how to identify the corpus callosum. You will be seeing lesions which involve the corpus callosum. So you should know which is the genu and which is the splenium. Of this black area here that is joining the two occipital lobes is the splenium, the two frontal lobes is the genu. So in this image, we are trying to understand fornix, genu and the splenium. The next is this CT scan image. In this CT scan image, you can see here, this is the frontal horn of lateral ventricle, this is the occipital horn of lateral ventricle. You see a gray matter touching the frontal horn of lateral ventricle, this is the caudate nucleus. This is the gray matter on either side of the third ventricle, this is third ventricle. So on either side of the third ventricle, these are your thalami. So caudate nucleus is touching the frontal horn of lateral ventricle. The third ventricle on either side will have thalamus. Just posterior to third ventricle, this is your pineal gland. Pineal gland. Within the occipital, this soft tissue we are talking about, this soft tissue. So within the occipital horn of lateral ventricle, these are the occipital horns of lateral ventricle. Within the occipital horns of lateral ventricle, we have the choroid plexus, right? So choroid plexus. So pineal gland is located behind the third ventricle. Choroid plexus is located within the occipital horn of lateral ventricle. And where do we have the lentiform nucleus? The lentiform nucleus is this one. This is your lentiform nucleus. And what is the outer part in the lentiform nucleus? The outer part is the putamen, and the inner part is the globus pallidus. Inner part is the globus pallidus. So this is different parts of the basal ganglia that you need to know. Let me do it once again for you. This is caudate, the gray matter touching the frontal horn. These are the thalami on either side of the third ventricle. This is the lentiform nucleus. Outer part is putamen, inner part is globus pallidus. This is your pineal gland, just posterior to third ventricle. This gap is the third ventricle. These are your choroid plexus, right? So choroid plexus. So that is how they have different parts of the basal ganglia. I hope you can get. And please remember, this is always the right side. This is the left side. This is the anterior part. This is the posterior part. Always imagine that the patient is lying down with his legs facing you. Imagine I'm lying with my legs facing you. You are cutting me slice by slice. So this side will be the right side. This side will be the left side. So always when you look at axial images, have that orientation. You are standing at the foot end of the patient. Your patient is lying down with his legs facing you. You are cutting him slice by slice. So do not confuse which is right caudate, right thalamus, left thalamus. Okay, let's go forward. Now some important ENT radiological images are there. So look at this image here. This is a CT scan. You can see the bone is white, the subcutaneous fat is black. So this is CT. Now this is a coronal section showing this opacification of your left sinuses. The left ethmoidal and the maxillary sinus, they show this thickening, mucosal thickening. And if you see carefully, there is two different densities here. So this is called as double density sign on the CTPNS. Anybody can tell me, where do you see this double density sign on CTPNS? Which one will show this double density sign on CTPNS? Anybody can tell me, where do you see this thing from your ENT double density sign? Please remember, double density sign, you understand this is sinusitis. So one thing we understand, there is involvement of the sinuses. So this is sinusitis. Now, if it was, fungal sinusitis, you see hyperdense elements, but this classic double density sign is feature of allergic. It is important to remember allergic fungal sinusitis. We need to give steroids when it is allergic. The charcut-laden crystals that you see in allergic conditions like asthma and allergic fungal sinusitis, right? This is the one which is hyperdense. These are more hyperdense. So you have mucosal thickening and you have these charcut-laden crystals which are more hyperdense, right? The allergic response, right? So allergic response. So together they form this double density sign. So the mucosal thickening will form one type of density, and the allergic response along with the fungal elements, the charcut-laden crystals along with the fungal elements will appear more hyperdense, giving this double density sign. So double density sign is feature of allergic. Remember the word allergic. You need to give steroids. Allergic fungal sinusitis. The next thing. Now look at this image. This is a axial section. This is the right maxilla. This is the left maxilla. And you can see in the right maxilla, if you look at the maxillary sinus here and compare it with this, you are seeing that the right maxilla is much smaller. The right maxillary sinus is much smaller. So just by comparing, you can tell that the right maxillary sinus is appearing smaller than the left side. And if you understand what exactly is happening here, this is showing a mass in the pterygopalatine fossa, which is causing this anterior bulging of the posterior wall. There is anterior bowing or anterior bowing of the posterior wall of maxillary sinus. This is seen in an adolescent male with epistaxis called as a Holman-Miller sign or antral sign. So how do we identify it? Compare the maxillary sinuses. If you see unequal maxillary sinus, look at it more carefully. You will see an anterior bowing of the posterior wall of maxillary sinus called as Holman-Miller sign. Anybody, where do you see this sign? This, I hope all of you could know this. This is classic of juvenile nasopharyngeal adolescent age group, right? Nasopharyngeal angiofibroma, epistaxis, right? Vascular angiofibroma, right? So this is about Holman-Miller sign. Next thing. These are CT scan images. This is a plain CT and this is a contrast CT. If we have, imagine these are your dural venous sinuses, right? So this is the superior sagittal sinus, right, which is like this. You all know the superior sagittal sinus, the inferior sagittal sinus, then the straight sinus. They all unite and form the confluence of sinuses, right? Then we have transverse sinus like that. If I have a thrombus in the superior sagittal sinus and I take a section, on the posterior part, there will be a more hyperdense area in the posterior part of the falx. So that is called as a delta sign. So delta sign is this hyperdense strangler area that you are seeing in the posterior part. But if I give contrast, the contrast will go around it The contrast will go around it. So if I do a CCT, I will see that the contrast is going around this area of thrombus. This is called as empty delta sign. So both delta sign and empty delta sign, these are features mainly of superior sagittal sinus thrombosis. Remember, you're looking at the posterior part of the falx. It is not a lateral or a transverse. It's mainly what? A superior sagittal sinus. So please remember, superior sagittal sinus thrombosis. Superior sagittal sinus thrombosis on the posterior part of the falx, right? So it is a superior sagittal sinus that is located here, right? So at the posterior part of the falx, you will see this delta and empty delta sign. What is the difference? Delta sign is seen in non-contrast CT. Empty delta sign is seen in a contrast enhanced CT scan, right? There is a power cut here, right? So, and we are working on the inverters and stuff. So it's slightly humid, but I hope, you know, it's not very difficult for you to catch up, right? So anyways, if there is anything problematic in between, just manage with it. Okay. So anyways, I hope it's fine so far. Delta sign, empty delta sign. Empty delta sign is seen in case of CCT, and delta sign is seen in what? Non-contrast CT scan, non-contrast CT. Now, let's come to the next one. What do you think is this CT scan image showing you? At what level? This is at the level of the mediastinum, right? At the level of the chest. So you can see this is the right lung, this is the left lung. This is the anterior part, you can see the sternum here. This is the posterior part, you can see the vertebra. And on the posterior side, you're also seeing the scapula. And this vessel, which is seen on the anterior part here, this is your ascending aorta. This is the ascending aorta. This vessel here, posteriorly, is the descending aorta. So we understood ascending and descending aorta. To the right of ascending aorta, the right side, this is superior vena cava. So this vessel is the superior vena cava. To the left of ascending aorta, this is the main pulmonary artery dividing into right branch and a left branch, right? So this is your different anatomy that you need to know. So it's simple only. You know the arch of aorta, right? You know the vena cava that is formed by the left and right brachiocephalic veins joining and forming the superior vena cava. You also know the pulmonary artery like this. So you're taking a section here. So this is the ascending aorta. This is the descending aorta. To the right, so this is right side, right? So to the right is superior vena cava, and to the left is main pulmonary artery. The same thing you are seeing. So anteriorly you have ascending aorta, posteriorly you have descending aorta. To the right is your superior vena cava, to the left is your main pulmonary artery. And you can see the right and left branches of the pulmonary artery also. So that you need to understand this image, very important for your anatomy, okay, radiological anatomy. Good evening, Aman and Amar, and hope you're all good. Rohit and comfortable with this slice, all of you? Can we move to the next one? Can we move to the next one? Okay. Look at this image now. If you have understood the anatomy, you should be able to tell what is the problem here. What is the problem here? Which artery is involved here? This is the ascending aorta that is involved. And you can see here, this is the double lumen with intimal flap. Double lumen with intimal flap. This is ascending aortic dissection. What you're seeing here is a ascending aortic dissection. And remember, aortic dissection is most common in the ascending aorta, right? More common. This is called as Stanford A. Stanford A. And when it is Stanford A, when it is involved ascending aorta, because coronaries, they come from ascending aorta, it becomes important to correct it surgically. So the treatment will be surgical management. Surgical management. Remember, if it is descending aorta, you call it Stanford B, and we generally go for medical management if the descending aorta is involved, right? Control of hypertension like that. So, you know, basically Stanford A are more common. Stanford A, you should go for a surgical correction. And if I ask you among them, which is true lumen and false lumen? Imagine this is A, this is B. Can you tell me which is true lumen in this? Which is true lumen, guys? Can you tell me A or B? Which is the true lumen? Which is the true lumen in this? Very good, cortex, very nice. So anything which is more smaller, right, having more contrast, this is true lumen, this is false lumen. So true lumen and false lumen, if we try to compare them, true lumen has more contrast, this has less contrast. True lumen is generally smaller in size, this is larger in size, right? And when you have this aortic dissection, so you have this tennis ball like area, right? So imagine this is the aorta. This is the aorta with an intimal flap. So the false lumen will form a beak-like area, and you'll see so lot of shreds of tunica media. So those are called as beak sign and cobweb sign. So these are features of the false lumen. So that is how we differentiate which is a true lumen and a false lumen. The beak sign, the cobweb sign, less contrast, larger in size is a false lumen, right? Now let's come to the next image. Now look at here. You're looking at a CT anatomy of the heart. The most anterior chamber is the right ventricle. So this is how we have the right ventricle. And this is the sternum, and this is the right ventricle. So whenever the right ventricle enlarges, the retrosternal space will be lost. So retrosternal space is obliterated. The retrosternal space is obliterated, right, in cases of right ventricular hypertrophy. The most posterior chamber in the body is the left atrium. And you can also see these are the pulmonary veins that are opening into left atrium. So whenever we have a left atrial enlargement, it will go posteriorly and compress the esophagus. So whenever we have a left atrial enlargement, there is anterior indentation of the esophagus. The anterior part of the esophagus will get compressed, especially in mitral stenosis. On a barium study, you will see anterior indentation of the esophagus. Once again, try to understand. The most anterior chamber of the heart is right ventricle. The most posterior chamber of the heart, the chamber which is receiving the pulmonary veins. You can see the pulmonary veins are entering into it. So the chamber that is receiving the pulmonary veins is your left atrium. The retrosternal space gets obliterated in right ventricular hypertrophy, and the left atrial enlargement will cause compression of the esophagus. Next, this is your CT scan image, axial section, showing this is the right lung, this is the left lung. But you can see here there is an area with absent bronchovascular marking. And you can also see the visceral pleura is being reflected. So when you see absent bronchovascular marking, the visceral pleura being separated, this is suggestive of a pneumothorax. What are these black areas in the subcutaneous planes in a patient with trauma? So this second arrow here that I have kept the star mark, this is nothing but your subcutaneous emphysema. So whenever we have trauma, so that is how you have the subcutaneous emphysema in a patient, right? So that is how you need to identify these images on the CT scan. Remember, investigation of choice for air anywhere, for any pneumo, for air is CT. So it can be either pneumothorax, pneumocephalus, pneumoperitoneum, or it can be paranasal air sinuses, right? It can be mastoid air cells, or it could be anything, which is having air containing infections like emphysematous cholecystitis, emphysematous pyelonephritis, or when you have distended air fluid bowel loops, right? So air filled bowel loops you have, so intestinal obstruction you have. So any intestinal investigation of choice for intestinal obstruction. So please remember, all of this for air anywhere is CT. Remember CT for ABC. For air, bone and calcifications, we generally go for CT. So for air containing areas like for pneumocephalus, pneumothorax, pneumomediastinum, right? Pneumoperitoneum, anything with pneumo, even pneumomediastinum, right? So anything with pneumo, paranasal air sinuses, mastoid air cells, emphysematous infections, emphysematous cholecystitis, emphysematous pyelonephritis. For all of these, the investigation of choice is a CT scan, right? Let's come to the next one. Let us look at some indications where we use non-contrast CT and when should we use CECT. As I told you, when we're trying to look anything white, there is no need to give contrast. So if you're trying to look anything white, right, there is no need to give contrast. If already it is calcification, why do you want to give contrast? Already it will appear white. So for any case which is like calcic calculi, right, ureteric stones, ureteric calculi, or stones basically, or any calcifications you want to see. Head trauma, remember you're trying to look at the bleeds, the acute hemorrhages, and remember acute bleed is hyperdense. Acute bleeds, they are hyperdense. The acute bleeds, they are hyperdense, having Hounsfield units of, it is white, hyperdense or white. It is having a Hounsfield unit of 60 to 70, plus 60 to plus 70, right? So this is white. So anything which is having a white appearance, you go for a plain CT, right? So acute subarachnoid hemorrhage, acute bleeds are, hyperdense, head trauma to look for all the types of bleeds, renal calculi, stroke patients. Remember, whenever you have a stroke or cerebrovascular accident, the initial investigation or the investigation of choice is non-contrast CT. If it is hyperdense or white, it is hemorrhagic stroke. And if it is hypodense or normal, sometimes CT scan may be normal, this is ischemic stroke. Ischemic stroke. So for all these conditions which are appearing white, the hemorrhagic stroke will appear white, ischemic stroke will appear black. To differentiate that easily, we'll go for a plain CT, non-contrast CT. So for looking at head trauma, acute subarachnoid hemorrhage, calculi or stones, to look at, stroke patients, we go for a plain CT scans. Coronary calcifications also, the Augustin scoring is done for this, right? So the Augustin scoring that we do for coronary calcification is done on a plain MD CT, plain CT. So you don't want to do contrast when you want to look at calcification. Now coming to CCT, CCT is used to look at, which organ is involved in abdominal trauma, to know the organ of injury in abdominal trauma. We go for CCT. I taught you that yesterday, that when you do fast, we look at the fluid around the heart, around the liver, around the kidney, like that. But if you want to know which organ is responsible, right, when there is hemoperitoneum, you want to know, is it the liver injured, is it the spleen injured, what is the cause for hemoperitoneum, which organ is injured, you will go for a contrast CT. Wherever the contrast is leaking from, that is the organ that is injured. If it is leaking from the liver, it is liver injured. If the contrast is leaking from the spleen, there is contrast blush, right? So that indicates there is splenic injury. So that is the reason we go for a contrast CT for knowing the organ that is injured in abdominal trauma. And to look at vascular lesions like tumors, infections, inflammations, right, whichever have a lot of vasodilation, right, for example, inflamed areas are there like pancreatitis, appendicitis, infected areas like tuberculosis, for all of this, and even tumors, right, RCC, lung cancers, for all of these, the investigation, we try to go for contrast CT. The contrast will go more in these areas because of the vasodilation in that areas. So that is the reason we go for a CCT in these areas. Are we clear with this? So this is for CCT. So abdominal trauma, any vascular areas that you have, wherever areas where vasodilation you are expecting, like tumors, where you have a lot of angiogenesis, or inflammation areas like pancreatitis, infected areas like, ileocecal tuberculosis, renal tuberculosis, or you are having appendicitis, you go for a contrast enhanced CT scan. Next, look at this image. This is a coronal CT scan. The bone is white, the vertebra, the femur and everything is appearing white. And can I ask you, what are these thick arrows that are pointed to? So look at the white arrows, the thick arrows, what is it pointing to? Can you tell me what is the thick arrow pointing to? The thick arrows are pointing to these paravertebral muscles, the psoas muscles, right? So these thick arrows, they are pointing to the psoas muscles. These are the psoas muscles. So in tuberculosis patients, when they have pot spine, psoas abscess, you need to know to look at the psoas muscle. And what is this thin arrow? What is this thin arrow that is pointing to? So this muscle here in the iliac fossa, this is iliacus. Okay, so this is iliacus. Together they form the iliopsoas muscle, right? So the psoas muscle and the iliacus. So here also you can see on the right iliacus muscle and the right psoas muscle, right? So I hope you can get them right. One exam they had asked, what is the muscle that is inserted on this structure, and they gave this radiograph of the femur and they asked what muscle is inserted here. So basically they asked the muscle inserted on lesser trochanter, muscle inserted on the lesser trochanter. So the muscle inserted on the lesser trochanter is your, what is the muscle inserted on lesser trochanter? It is the iliopsoas muscle. They form a common tendon and insert on the lesser trochanter. It is the chief flexor of the hip, right? So chief flexor of the hip is also your iliopsoas. So you will get a lot of questions on the iliopsoas muscle. Okay, next. So let's look at the CT of the abdomen. So when you're looking at the CT of the abdomen, this is the aorta, right? These are the right kidney and the left kidney. So you can see here, this is the right kidney, this is the left kidney, this is the liver, gallbladder. You can identify the pancreas. This structure with microgyrations that you're having, right? This is your pancreas, right? So small, this one, this is the pancreas, this is the spleen that you have. But the important thing is to identify the vessels. For identification of the vessels, please understand the vessel that is present between the two crura of the diaphragm. These are the crus of the diaphragm, that is the aorta. To the right of aorta, this is vena cava, right? So I'll draw it in a blue color so you can identify it. So this is the IVC here. So to the right, you know which is right side, which is left side. To the right of the aorta is a vena cava. Just posterior to the pancreas, neck of the pancreas, this vessel is the portal vein. So that is how you identify the different vessels. The only thing difficult here is the vessels. Try to identify all the other structures you can manage, right? Liver, spleen, kidneys, or pancreas you can manage. Only thing is the vessels. Aorta is present between the two crusts of diaphragm. To the right of aorta is vena cava. Just posterior to the neck of the pancreas is your portal vein. And this vessel, which is going posterior to the pancreas, right, supplying major part of the body of the pancreas and going towards the spleen, which will be involved whenever there is pancreatitis also. This is your splenic artery. So this large vessel that is going behind the body of the pancreas, right, posterior to the body of pancreas, going towards the spleen, that is your splenic artery. And can I ask you, what are these black arrows that are pointing here? These black arrows that are pointing, these are nothing. These are triangular or inverted Y-shaped structures. Can you tell me what are these? What are these black arrows? These black arrows in the image, these are pointing to, very good, these are your adrenal glands, right? So let us identify the adrenal gland once again. So the black arrows that you're having, which are these inverted Y shape or triangular structures, these are your adrenal glands. Let's move to the next one. So if you're seeing a patient with trauma and you are seeing contrast extravasation from the liver here, this would be what? Hepatic injury. Okay, hepatic lacerations or hepatic injury, there will be contrast extravasation from the liver, and that is the reason we say it is the CECT that tells you the organ injured, right? The organ of injury in abdominal trauma. Organ of injury in Varun, please hold on. I'll explain you, Varun. Okay. So we'll have that discussion in a later point of time. Next thing, look at another image. Again, what is this? This is CT. The bone is white, so this is CT. And you can see there is contrast inside the blood vessel, aorta. So this is contrast CT. So you can see the contrast enhancement of the vessels of the kidney. You can see contrast in the hepatic vessels. So you are having a contrast enhanced CT in a patient with trauma. And what is the condition here? If you see carefully, you can see that the right kidney is enhancing, but the left kidney is not enhancing. So this is, as we learned yesterday, this is a condition where you have non-enhancement of the one kidney. This is grade 5 renal injury, grade 5 renal injury. And this is a left renal vascular pedicle injury, vascular pedicle injury or renal hilum injury, right? So there is non-enhancement of that kidney, right? So please remember that, right? Now let's come to the next part. This is right side. You can see this is the right lung, this is the left lung, and how do I go for this? 1 minute. Okay, so this is the right lung and this is the left lung, and you can see here in the coronary artery, the left anterior descending on the left side and on the anterior part, the left anterior descending artery is showing calcification. So this is an area showing a LAD calcification, right? So LAD calcification. So I told you what is the calcification scoring called? That's called as Agatston scoring. And you want to do a plain CT or a contrast CT, to look at calcifications, we go for a plain CT. And whenever you're going for cardiac CT, especially coronary CTs, we want to look at, we know the major coronaries, they fill in mid-diastole, right? So the filling of coronaries happens during diastole. So usually the cardiac CTs are advised, okay, there is ECG gating, and we take the images mainly in the mid-diastole because the coronaries fill better and you can visualize the coronaries better in the mid-diastole. So that is about your Agatston scoring system. Then in a CT scan, we can reconstruct, and volume reconstruction of the images can be done, and you can get an endoluminal view inside, okay, the lumen also you can see. These reconstructions, these 3D CT reconstructions, these can be CT colonoscopy, basically a 3D CT reconstruction that we have to look at, the colonic polyps or masses. We can go further. 3D CT in general practice, we use it for complex facial fractures, right? So complex facial fractures to look at pelvic fractures, right? So a lot of bones will be there. So you want to look at small fractures, right? In the facial fractures, pelvic fractures, we advise a 3D CT. And the similar 3D CT technique to look at the bronchial tree, this is your virtual bronchoscopy. And even virtual bronchoscopy is a 3D CT technique which can give you endoluminal view. These will give you endoluminal view. And the good thing, better thing about these 3D CT techniques, so CT colonoscopy is CT using virtual bronchoscopies, is that you can go beyond the area of stenosis also. These things can look at post-stenotic areas where you cannot put your endoscope and go. Okay, the advantage of the CT colonoscopy and virtual bronchoscopy over a regular colonoscopy and a regular bronchoscopy is these can look at post-stenotic areas, right? Obviously, biopsies are done with actual colonoscopy and actual bronchoscopy, but sometimes the probe you cannot go beyond the area if there are some secondaries or there is some other pathologies beyond the area of stenosis. You can look at those post-stenotic areas by these 3D CT reconstructions, the CT colonoscopy or virtual bronchoscopies, right? Obviously, virtual bronchoscopy would be non-invasive. Coming to HRCT, Varun had been asking about HRCT continuously. We'll take that up. Coming to HRCT, high resolution CT scan. It differs from a regular CT scan that it uses thin slices, very thin slices of about 1 to 3 mm. Generally, CT scan we take about 1 centimeter, but when you say HRCT, you take very small slices. And in HRCT, we use a special software, like a special application called as bone algorithm, which makes the images appear much sharper. Coming to the indications of HRCT, HRCT is used for interstitial lung disease. Whenever we want to look at the septal thickening, interstitial septal thickening, the interstitial lung diseases, for bronchiectasis, for CT cysternography, to look at the fracture of the cribriform plate, you need to have thin slices, right? So you cannot take thick slices. You want thin slices to look at the fracture of cribriform plate, to look at CS rhinorrhea for CT cysternography. And even when we have fractures of temporal bone, especially the petrous temporal bone, which can lead to ear-ossical disruption. So whenever we have a conductive deafness after head trauma, we are suspecting ear-ossical disruption. And remember, the ear-ossicles are small bones, malleus, incus, stapes. So you will see that, to look at these very small bones, you have to take thin slices, and that is your HRCT. So you can remember the indications of HRCT like this. Okay, so this is HRCT. If you see carefully, you can see HRCT there. So remember, interstitial lung disease, bronchiectasis, just write it like this, right? CT cysternography, even COVID cysternography, you do all your corads and all, right? So COVID also, so you can use that C also. And fracture temporal bone, fracture temporal, especially petrous temporal bone, or conductive deafness after head trauma. These are the indications of HRCT. Are we okay, Varun? Let's come to the next one. Ice cream cone appearance. Ice cream cone appearance on HRCT. Remember, be careful, ice cream cone appearance, whether they said HRCT or whether they said MRI brain. On CT, we look at bones, right? The malleus, incus, stapes. So this malleoincudal joint, the first two, malleoincudal joint, right? So that will give you the ice cream cone appearance on the ear ossicles, the first two ear ossicles. On MRI brain, this is your vestibular schwannoma, right? Previously called as acoustic neuroma. The correct name is vestibular schwannoma. It arises from the vestibular nerve. It arises from the Schwann cells. So, vestibular schwannoma at the CP angle will give you the ice cream cone appearance, right? So please be careful with what they asked in the exam, whether it was HRCT or whether it was MRI brain. So don't blindly write vestibular schwannoma or acoustic neuroma on the exam. Better, look carefully. If they say HRCT, malleoincudal joint. The first two, right? Malleoincudal joint. And if they asked you MRI brain, obviously it is the vestibular schwannoma. Then coming to some questions, we'll try to see if you're all listening. So just try to answer this question. A 25-year-old female with severe headache is advised a CT scan of the head. Which of the following history will you definitely ask before doing the CT scan? So there is a 25-year-old female with severe headache and CT scan was advised. And which of the following history will you definitely ask? Okay, which history will you ask, right, before doing the CT scan? History of fall, cochlear implant, last menstrual period, history of hypertension. So very good. So what is this is this is a female of reproductive age group. So whenever we have a female of reproductive age group and you are doing for a diagnostic modality using ionizing radiation, we follow a rule called as 28-day rule. We ask for the menstrual cycle, right, before we go for any diagnostic modality which is using ionizing radiation. So if she says she had a proper menses on the regular date, we go ahead and get it done. But if she says that her menses had not come, we always go for a pregnancy test, then we go for this diagnostic modality. So okay, so it's very important to follow this 28-day rule, to look at especially when you're dealing with a female of reproductive age group where you can expect a undiagnosed pregnancy to be present, right? So it's important to follow this thing. And the cochlear implant, this is used for MRI. This is a MRI will be contraindication for that. Okay, so MRI will be contraindication in a patient with a cochlear implant, right? So please remember the answer should be last menstrual period. Next thing, a whole body CT scan for trauma. So in a patient with trauma, when we advise whole body CT, it includes all except what is not included: CT of the spine, CT of the limbs, head CT or abdominal CT, which is not included when we say whole body CT. Anybody? So whenever you have a patient with polytrauma, right? In a polytrauma patient, we advise non-contrast CT of the head to look at any head trauma. I told you in head trauma, we go for a non-contrast CT. We have to go for a non-contrast CT of the cervical spine to look at any fractures, okay, any disruptions there. We go for CCT of the thorax, right? Look at any injury to the mediastinal vessels, and also we go for CCT abdomen to look at any organ that could be injured. So limbs are not done when we see whole body CT. So whenever you're having a polytrauma patient, right, multiple trauma areas of injuries are there, you want to rule out any problem anywhere, you generally go for this thing. You go for a non-contrast CT of the head, you go for non-contrast CT of the cervical spine, you take a CCT of the thorax and the abdomen, but not of the limbs. Next, we go to MRI. MRI, remember, it is based on gyromagnetic property of H plus ions, right? Gyromagnetic property of H plus. And this uses NMR, that is nuclear magnetic resonance. Magnetic resonance. And if you look at the indications of MRI, there are a lot of places where MRI is the investigation of choice. So I've clubbed them as neuroimaging, cardiac imaging, women imaging, ortho imaging, and we'll try to understand one by one. So when I say neuroimaging, it is both brain and spine. So whether it is brain tumors, infections of the brain like encephalitis, injury, diffuse axonal injury, right, where the CT scan can be normal or may just show petechial hemorrhages, right? So a patient who is having trauma, unconscious, poor Glasgow coma scale, when he got a CT scan, it is normal. So a trauma patient who is unconscious and the CT scan is normal, please be more worried. It could be more dangerous, the diffuse axonal injury. So an unconscious patient after trauma, poor Glasgow coma scale after trauma, CT scan is normal or just shows petechial hemorrhages, it could be diffuse axonal injury. The investigation of choice is MRI. So even in demyelination disorders like multiple sclerosis, the investigation Okay. Is it audible now, guys? Is it better? Can you hear me? Just give me a quick thumbs up if you can hear me clearly now. So for both brain and spine, right? So for both and brain and spine, for all neuroimaging, anything to do with the word spine, you go for MRI, right? Anything to do with the word spine, we go for MRI, whether it is spinal metastasis, spinal trauma, spinal cord injury without radiographic abnormality, TB spine, that is spot spine, right? Ankylosing spondylitis. So anything to do with spine, right? Go for MRI. Even prolapsed intervertebral disc, which can cause spinal cord compression, any traumatic paraplegia. So the word is spine, right? The investigation of choice is MRI. For cardiac imaging, the MRI is investigation of choice for cardiomyopathies, like, HOCM we have, or arrhythmogenic right ventricular cardiomyopathy. So all these cardiomyopathies also, dilated cardiomyopathy, HOCM, ARVC. For cardiomyopathies also, the investigation of choice is MRI. The preferred investigation, right, for myocarditis also, post-COVID also we are having myocarditis. So the myocarditis also is evaluated by MRI, right? The gold standard is endomyocardial biopsy, but would not want to go for that, right? Imaging MRI can show you the myocardial edema in cases of myocarditis. Myocardial scar after MI. So whenever we have a myocardial scar, right, that area will show late gadolinium enhancement. So you can go for a contrast enhanced MRI. So even for myocardial scar, right, so go for MRI. So remember cardiomyopathies, myocarditis, myocardial scar. Once again, myopathies, right, cardiomyopathies, myocardial scar and myocarditis. And also the most accurate for ventricular function is a cardiac MRI, the cine MRI that we do, right? So cardiac MRI is also the most accurate, better than echocardiography for ventricular function or ejection fractions, right? So these are the indications in the MRI. So once again, so investigation of choice for cardiomyopathies, investigation of choice for myocarditis, investigation of choice for myocardial scar after MI, and also for ventricular function, we go for MRI. There are a lot of indications of MRI in women imaging. We go for high-risk screening of breast cancer as well as screening of breast cancer in young patients, right? High risk for breast cancer, high-risk screening of breast cancer in young patients, right? So for all of them, we go for MRI. For patients with breast implants, right, anything with the placenta increta, percreta, where we are trying to look at invasion of the placenta in the myometrium, right, pelvic adenomyosis, where the endometrial glands are invaded into the myometrium. So for all these conditions, right, investigation of choice is MRI. So once again, for high risk screening and screening of young patients for breast cancer, placenta increta, percreta, pelvic adenomyosis, and in breast cancer patients to differentiate scar tissue from recurrence. Anywhere else, we go for PET scan. But in the breast, a contrast enhanced MRI has equal sensitivity, and being a non-ionizing is preferred over PET scan for breast cancer, only for breast. Any other organ, if you want to know whether there is a scar or there is a recurrence there, we go for an 18 FDG PET. But for breast cancer, a contrast enhanced MRI is better and equally and better sensitive than a PET scan. So, it is advisable to go for contrast enhanced MRI over PET for breast cancer alone. Okay, other places PET scan will be better. So these are important indication in women imaging. Ortho imaging, MRI is also a very important investigation for orthopedic imaging. For ACE, remember ACE, 4A's, avascular necrosis in young, that is Perthes disease. You have acute osteomyelitis, you have ankylosing spondylitis, right? So for all of these, you go for MR. Even in march fracture and stress fractures, right? These are the same. So march fractures or stress fractures, there'll be marrow edema before cortical break. So to look at marrow edema, we go for MRI in stress fractures or march fractures. So march fracture or stress fracture. So you can remember this list for MRI. So all of these, the investigation of choice is MRI. So brain, so neuroimaging, what are there in orthopedic imaging, women imaging, right? Cardiac imaging. Please remember, just put some effort, you'll learn it. Coming to, there are some P's of MRI where the investigation of choice is MRI. So all of them start with the word P, right? So all of them, they start with the word P. So try to concentrate on that. So what are they? Any posterior fossa lesions, Pancoast tumor, it's an apical lung cancer. Pancoast tumor is apical lung cancer because of its invasion into brachial plexus, right, and the subclavian vessels. To look at vascular invasion, neurovascular invasion, MRI is better. Posterior mediastinum is mostly neurogenic masses, right? So they are mainly neurogenic masses. So to look at any neurogenic masses, obviously you would go for a MRI. Pot spine or TB spine, just now anything to do with spine, the word spine, MRI. Traumatic paraplegia, prolapse intervalvular disc, Perthes, that is avascular necrosis, pelvic adenomyosis, placentine creta percreta. So remember, go from top to bottom. Posterior fossa lesions, right, to look at Pancoast tumor, posterior mediastinum, pot spine, right, traumatic paraplegia, prolapse intervalvular disc, and pelvic adenomyosis, right, and placentine creta percreta. So just go in an order, you will be able to get all the indications. Once again, posterior fossa, you have Pancoast tumor, you have posterior mediastinum, pot spine, traumatic paraplegia, prolapse intervertebral disc, right, and anterior, right, the placentine creta percreta and the pelvic adenomyosis. So remember these P's where the investigation of choice is MRI. Next, coming to contraindications of MRI. Remember, any ferromagnetic compounds like intraocular metallic foreign body, you have cardiac pacemaker, cochlear implants, any patient with claustrophobia. Swansgan's catheter has a metallic tip, so even that is a contraindication for MRI. So this intraocular metallic foreign body, you will be given a history of a patient working with hammer and chisel. So remember, whenever you are having this intraocular metallic foreign body, the investigation of choice is CT. MRI is contraindicated. So any ferromagnetic substance, electrostimulatable devices, right, MRI will be contraindication. Also remember what are not a contraindication. Copper T is not a contraindication. Coronary stents are MRI compatible because they have the same pathology. Tomorrow when we have stroke or this MI, these patients will have similar pathology, right? So we want to have MRI compatible stents only. So most of the coronary stents are MRI compatible. Titanium is not ferromagnetic. Titanium is, diamagnetic. It will have poor magnetic impulse, so it will not give you that much of response on the MR. So titanium based implants, the orthopedic implants, they are safe to get MRI done. Okay, remember, avoid MRI in recent orthopedic implants. Nothing much will happening, but loosening of the graft will happen. So avoid it till it gets fixed with the bone. So avoid in recent orthopedic implants, but as such titanium based implants or orthopedic implants are not a contraindication for MRI. Copper T is not an indication. Coronary stent is not an contraindication. Even rubber catheters, Foley's catheter, Riles tube, they are not a contraindication. Swansgan's catheter is a contraindication of MRI. Now let's come to the next thing. In MRI, we have a spin echo sequence, the basic sequence, which we have T1 weighted imaging, T2 weighted imaging. T1 weighted imaging is basically for anatomy. T2 weighted imaging will show you pathologies better. And I will not go into a lot of physics now, but few words I want to remember. T1 is spin lattice interaction. Remember L for lattice. T2 is spin, 2 times the word spin is coming, or S for a second, right? T2 is spin interaction. T1 is L for L, gain in longitudinal magnetization. T2 is loss of transverse magnetization. And T1, one is small number, will have short time to echo and time to repeat, called as TR, time to echo and short time to repeat. I'm not explaining this is a revision class, so I'm not explaining all the physics behind it. I've done that in detail in the lecture videos and doctor tutorials, but here I'll just briefly, tell you what to remember. One is small number, remember short T, short TR. T2 is big number, so long T, long TR. Long T, long TR is for T2 weighted image. So remember this much, that should be fine. Once again, T1 is spin lattice interaction, T2 is spin interaction. T1 is gain in longitudinal magnetization. Again, you can use the word L, right? T1 is longitudinal magnetization, there is gain in longitudinal magnetization, and T2 is loss of transverse magnetization. T1 has short time to echo, short time to repeat. T2, big number, has long T, long TR. Now coming to the appearances. Remember, to call it an MRI, whether it is T1 or T2 doesn't matter. Remember, the difference between CT and the MR is CT, the bone is white and the fat is black. Opposite is correct in MRI. The cortical bone is dark on MRI or hypointense, and the fat, the subcutaneous fat, is white on both T1, T2. On both T1 and T2. So basically that is a difference. So whether it is T1, T2, this holds good. So whether it is T1 or T2, the bones are black and the fat is white. So bones are black and fat is white. So the difference comes by looking at the fluid signal. We all know World War II, water is white on T2. Water is white on T2. So basically the CSF or fluid is white on T2 weighted imaging and CSF is dark on T1 weighted imaging, World War II. Don't just stop at looking at fluid, also look at the gray matter and the white matter. The gray matter is gray and white matter is white. They go by their name. They go according to the name. Gray matter is gray, white matter is white in a T1 weighted image. And opposite of that, gray is white and white is dark on a T2 weighted image. Once again, we'll do this. First, T1, T2, how to differentiate them. T1, T2, whether it is T1 or T2, any MRI, right, whether it is T1 or T2, the bone will appear dark and the fat will appear white. To differentiate, look at the fluid signal. On T2 weighted imaging, the fluid will appear white, World War II, water will appear white. So whenever you're looking at the imaging from top to bottom to know which is T1 weighted MRI or T2 weighted MRI, concentrate carefully, look at the fluid signal. If you're given MRI of the brain, look at the ventricles. If you're given MRI near the orbit, look at the vitreous. Don't get confused by looking at retroorbital fat. Fat will always be white, whether it is T1 or T2. Look at the vitreous of the eyeball, right? Vitreous of the eyeball. If it is white, it is T2. If it is dark, it is T1. Do not get confused by looking at retroorbital fat. Like ventricles, sulcal spaces, interhemispheric areas will be white on T2 weighted imaging. If you're given anything in the spine and stuff, always look at the CSF around the spinal cord. So any axial sections are given, try to look at the CSF around the spinal cord. If it is white, it is T2 weighted image. If you're given liver imaging, right, look at the gallbladder, look at the hepatic ducts. If they are white, it is T2 weighted image. If you're given the pelvic MRI, look at the bladder, look at the endometrial fluid. If it is white, it is T2 weighted imaging. So take home message, World War II, water is white on T2. Look at the fluid signal to know whether it is a T1 or T2 weighted MRI. Now let's look at it with examples. Look at here, the bones are black. So you can see here, the bones are black, right? And the subcutaneous fat is white. So this is MRI. To differentiate, look at the fluid signal. The CSF is dark in T1 and white on T2. Also look at the gray matter and white matter. In T1, it goes by the name. The gray matter is gray, white matter is white on T1. It is opposite of their name. The gray matter is white and the white matter is black on a T2. So you can see here, this is the caudate nucleus, the thalamus, right? So you can see the anatomy nicely on a T1 weighted imaging. Whereas your pathologies will be seen because you'll have edema, abscess, tumor, perilegional edema will be seen. The fluid will be white on T2. So pathology will be seen better on a T2 weighted image. So you have T1 and T2. So you can see here, the vertebrae are white. So this is again MRI. Try to look at the CSF signal around the spinal cord. If the CSF is dark, it is T1. If the CSF is white, it is T2 weighted imaging. So always try to look at the CSF on the spinal cord, whether you're given any sagittal section or axial sections also. Try to see the CSF around the spinal cord to know whether it is T1 or T2. All T1, T2, the bones are black, right? The bones are black on MRI, right? So I hope you can manage these differences. Because already on a T2, the sulcal spaces, the interhemispheric area, everything is white. If you give gadolinium contrast, right, you cannot identify it in the vessels because everything is already white. So that is the reason for contrast studies of MRI, we go for T1 weighted imaging. So it is better to look at T1 weighted imaging. In T2 already is already white. So rather than T2, contrast studies of MRI are done in T1 weighted imaging. I told you in breast implants, the investigation of choice is MRI. So whenever you have a intracapsular breast implant rupture, right, we have this sign where you have this wavy noodle-like areas called as linguine. So linguine sign, linguine. So remember IN for IN. So intracapsular breast implant rupture will show you linguine sign. And you can see here, this is a T1 weighted image, which is showing the anatomy nicely. You can see the basal ganglia structures, the caudate nucleus, the thalamus on either side of the third ventricle, the lentiform nucleus. Can I ask you, what is this gray matter surrounding the sylvian fissure? So what is this gray matter surrounding the sylvian fissure? This is your insular cortex, right? So insular cortex. So these are important. And this is the genu, this is the splenium, the white matter connecting the two occipital lobes. So this is the genu on the frontal, connecting the two frontal lobes, and the splenium of corpus callosum. So this is a T1 weighted image showing those structures. Next, this is a sagittal T1 weighted MRI. You can see the CSF in the ventricles is dark. This is the brainstem. You are seeing the midbrain. You are seeing the pons. Pons has a belly. This is the medulla. This is cerebellar hemispheres having the arbor vitae. This is your corpus callosum, right? So how do you identify the brainstem? Once again, the brainstem, the midbrain, pons, medulla. The pons will have a belly, right? This is medulla. This is midbrain, having the colliculi, right? And this is corpus callosum, having the genu, the splenium of corpus callosum. Above that, this gyrus is the cingulate gyrus. This is the pituitary gland, the anterior pituitary, and this bright area here, this is the posterior pituitary. Posterior pituitary will appear as a bright spot on a T1 weighted imaging. And please remember, the absence of bright spot, normally posterior pituitary will be a bright spot, will be bright spot on T1 weighted image. An absence of this will indicate, absence indicates diabetes insipidus, the central diabetes insipidus, right? So because of vasopressin, this area will appear as a bright area, proteinaceous content will appear white on this T1 weighted imaging. But if there is absence of vasopressin, that indicates central diabetes insipidus. So there will be absence of bright spot in central diabetes insipidus. Now coming to other structures, this is the fornix. Okay, this is the fornix, right? So this area here, this is the fornix. This is the optic chiasma, just above the pituitary. This structure is the optic chiasma, right? So these are the important structures that you need to identify: the corpus callosum, the cingulate gyrus, which is midbrain, pons, medulla, cerebellum, right? You can identify the pituitary gland, the anterior pituitary, the posterior pituitary, the optic chiasma. Next, look at this image here. This is a patient with hemiplegia. He's having right side hemiplegia. We got the CT scan done, right? I told you in stroke patients, the first investigation, the initial investigation has to be a non-contrast CT. The CT is appearing normal. There is no white area, there is no black area. The CT is appearing normal. So when the CT is appearing normal, and we advised a sequence of MRI called as diffusion weighted imaging. This is the most sensitive technique to look at acute infarcts, and you're seeing a very classic, right, wedge-shaped area involving the gray-white matter interface in the left MCA territory, telling you it is a left MCA infarct. So the most sensitive for acute infarct is a diffusion-weighted MRI, right? Diffusion-weighted MRI will show you this thing. Now, let us try to understand what are all the lesions which will show diffusion restriction. What do you mean by diffusion restriction? It will be bright on DWI, bright on diffusion-weighted imaging of MRI. Right? It will have low apparent diffusion. These areas will have diffusion restriction. So they'll have low apparent diffusion, right? Coefficient. Okay, low apparent diffusion coefficient. So whether they ask you which are the lesions showing diffusion restriction, or which are the lesions appearing bright on DWI, or which of the lesions will have low ADC value or apparent diffusion coefficient, mean the same, right? They mean the same. And you can learn this as I and me. Remember, if it is a narcissistic personality, it's all about I and me only, right? I and me, right? So that kind of personality, the narcissistic. Infarct, acute infarcts, abscess, medulloblastoma and high ciliary tumors, and epidermoid cyst. These are the lesions which will show diffusion restriction. So how to differentiate? Okay, I got an MRI done. I see a diffusion restriction. How to differentiate? Infarct, remember, will be wedge shape. So imagine this is a brain. I'll see an area which is bright, wedge shaped, involving a particular artery, like what you saw just now, right? That is how it will be. But if it is a abscess, abscess would be ring enhancing, right? A ring enhancing lesion which will show diffusion restriction, right? So that is how it will be, a diffusion restriction. Medulloblastoma will be a fourth ventricular tumor, right? So it is a tumor in a pediatric age group in the fourth ventricle. It's a very common malignant tumor in pediatric age group, and within the fourth ventricle, you will see diffusion restriction. It will be bright on diffusion weighted imaging. And epidermoid cyst, this is a lesion which is in the CP angle. So this is the cerebellum, this is the CP angle, pons, this is the cerebellum. Here you will have diffusion restriction. You will have a lesion showing diffusion restriction. So that is how you identify the epidermoid cyst. So based on the location also, you can easily identify. So once again, what are the lesions showing diffusion restriction? Infarct, abscess, medulloblastoma and epidermoid cyst. A wedge-shaped area in a particular arterial territory showing diffusion restriction is an acute infarct, right? Acute infarct. Ring enhancing lesion showing diffusion restriction will be a abscess. Fourth ventricular tumor, pediatric age group showing diffusion restriction would be medulloblastoma. A CP angle lesion, cerebellopontine angle lesion showing diffusion restriction would be epidermoid cyst. All of these will appear bright on diffusion weighted imaging, right? So, and they'll have low apparent diffusion coefficient. And what diffusion are we looking at? We are looking at the Brownian movements, right? So, this is a technique which is based on random free movement of molecules, the Brownian movements. So, when they are restricted, right, they appear bright on diffusion weighted imaging. There is another sequence of MRI that you should know, that is FLAIR MRI. Now, FLAIR is fluid attenuation inversion recovery sequence. FLAIR is same as T2. It is same as T2. What do I mean same as T2? The gray matter is white. The gray matter is white and the white matter is black, dark. Same as T2. Then what is the difference between T2 and FLAIR? As the name says, it is fluid attenuation. The fluid is suppressed. So the fluid will appear dark. In T2 World War II, water appears white, but here the fluid will appear dark. So you can see the ventricles here, right? The gray matter is white. You can see here that the gray matter is appearing white, but the gray matter is white, the white matter is black, but the CSF or the ventricles are dark. So it is fluid suppression that has happened, so that you can see this periventricular hyperintensities of multiple sclerosis. So you can see all this involvement of corpus callosum, septum pellucidum. So all of this is seen. So this is FLAIR MRI showing the multiple sclerosis, the best sequence for multiple sclerosis. If it was T2, the ventricle would also be white and the periventricular hyperintensities would also be white. It will be difficult to differentiate. So the best sequence to look at plaques of MS, to look at those Dawson fingers, the plaques of MS, they are best seen on a FLAIR MRI. So FLAIR MRI is the investigation that is preferred for multiple sclerosis. There is another sequence of MRI called as STIR MRI. STIR is fat suppressing. FLAIR was fluid suppressing, STIR is fat suppressing. So you suppress the bone marrow fat. So if your fat is also white on MRI, so if fat is white, bone marrow edema is also white, you cannot differentiate. You need to suppress fat to look at the bone marrow edema. So it is used to look at the bone marrow edema. For orthopedic imaging, we use STIR MRI. So short tau inversion recovery sequence called as STIR is basically to look at bone marrow edema like ankylosing spondylitis, osteomyelitis. So for all these orthopedic imaging, we advise STIR MRI. It is fat suppressing sequence, mainly used to look at bone marrow edema. So remember the investigation of choice for ankylosing spondylitis. Look, try to understand here. So look at here. This is a fat, subcutaneous fat. It is white. I am looking at a sacroiliac joint. There is some white area. It could be normal bone marrow also. Bone marrow has fat. Fat is white on MRI. How to know whether there is any ankylosing spondylitis, any sacroiliitis is there or not? I need to suppress the fat. So I have suppressed the fat and I still see some white areas. I know this is not bone marrow fat. This is bone marrow edema because fat is suppressed. This is bone marrow edema. So I know this is bilateral sacroiliitis that I am seeing. And this would be ankylosing spondylitis, right? So that is how STIR will help you by suppressing the bone marrow fat. The next sequence we have is susceptibility weighted imaging. The blood vessels will appear jet black, right, in the susceptibility imaging. And this susceptibility imaging is mainly used for three things: microhemorrhages, hemorrhage will become hemosiderin, and some calcifications. Along for these three structures, we use this susceptibility weighted imaging. Susceptibility weighted imaging is used for microhemorrhages. Microhemorrhages can be seen, or petechial hemorrhages can be seen in diffuse axonal injury. And if it is an elderly age group, vasculopathies like cerebral amyloid angiopathy can show you microhemorrhages. So in cases of diffuse axonal injury, in case of cerebral amyloid angiopathy, you will have these microhemorrhages or petechial hemorrhages, and these will appear as blooming artifacts. So imagine this is a T2 weighted image and this is a susceptibility weighted image. If I have a T2 weighted image, the areas of petechial hemorrhage may not be clearly seen, but the same areas, try to understand. So there are some areas which are not clearly seen, but those same areas become larger and darker, like flower blooming. You understand the word English meaning, right? Blooming of flower. So it becomes larger and darker. So that is what is called as blooming artifact. So those areas will become more darker and larger, called as blooming artifacts. You can see here, these are the blooming artifacts that you see in a susceptibility weighted imaging. So this is about susceptibility. So which will show blooming artifacts? Susceptibility weighted imaging. Around which structures you will see blooming artifacts? Whenever areas of microhemorrhages are seen in the brain, any kind of, patients with hemosiderin deposits or calcifications. Microhemorrhages, hemosiderin, calcifications, these show blooming artifacts on a susceptibility weighted image. If you are seeing blood vessels, if you are seeing the white matter tracts appearing very colorful, so if you are seeing the white matter tracts which are appearing very colorful, right? So this technique is called as tractography. Tractography. T40 tractography, or called as diffusion tensor imaging, not diffusion weighted imaging. DWI is different, that is for infarction. This is for acute infarcts we go for, right? Diffusion weighted imaging is different, diffusion tensor imaging is different. So this is diffusion tensor imaging, DTI, for tracts, for white matter tracts. And there is a color coding of these tracts, okay? So anything which is coming from superior to inferior, like the fibers going from corticospinal tract fibers, they will be blue color. You can remember as SBI, we have a bank called SBI, right? So fibers which are going superior to inferior will be blue color. Left to right fibers, like the corpus callosum fibers, right? The fibers which are going from left to right, they'll be red color, right? R for R, left to right are red color. And anterior to posterior fibers, the subcortical U fibers, these fibers, right? So which are going from on the same side, anterior to posterior side. So these will be green color. If you have bought any t-shirts, on that it will be written gap, right? You have seen any hoodies or t-shirts, gap will be written. Anterior to posterior will be green color. So let us try to understand. So the color coding will be there on the diffusion tensor imaging. So if you see an MRI image showing colorful images, that is diffusion tensor imaging. Diffusion tensor imaging is tractography, right, for white matter tracts. Superior to inferior fibers will be blue colors, anterior to posterior fibers will be green color, and the fibers which are going from left to right will be red color in diffusion tensor imaging. This is based on anisotropic movement in one direction. It is based on anisotropic movement. Diffusion weighted imaging is based on Brownian movement. Diffusion tensor imaging is based on anisotropic movements. Next, coming to functional MRI or fMRI. Functional MRI, as the name says, to look at functional areas of the brain. What do you mean by functional areas? The speech centers, the fine motor areas, the visual centers, right? So whenever these areas are activated, they'll take up more oxygen, right? So imagine I'm speaking, so my Broca's area will be taking up more oxygen at this point of time. And oxyhemoglobin and deoxyhemoglobin, they have different signal on MRI. So when you are getting MRI done and you ask the patient to speak or sing, you will be able to identify which area is showing changes between oxy and deoxyhemoglobin, and you can identify the Broca's area of the patient. Same thing, we can ask him to make fine movements of his hand. You can give visual stimuli, auditory stimuli, and identify those areas called as functional areas of the brain or the functional MRI. So this technique, which is based on oxygen levels, this is the BOLD technique, blood oxygen level dependent technique. BOLD imaging is blood oxygen level dependent technique. It is used by functional MRI and it looks at functional areas of the brain, the fine motor area, visual areas, basically brain mapping. All the brain we can identify giving different stimuli. Where are those functional areas in the brain? So you can map the brain before any surgical, neurosurgery procedures to give prognosis to the patient that this will happen, that will happen based on the location of the tumor. So this is brain mapping done by fMRI. Are you okay? This is fine, all of you? Did you understand these sequences? Let me just review through, just if you can identify or not. fMRI, diffusion tensor imaging for tractography, susceptibility weighted imaging for microhemorrhages, hemosiderin and calcifications, STIR imaging for bone marrow suppression, right? So bone marrow fat suppression or fat suppressing sequence. STIR, basically remember, orthopedic imaging. STIR is mainly for your orthopedic imaging. FLAIR is for multiple sclerosis, fluid suppressing sequence, right? And diffusion restriction is for I&ME, infarct, abscess, medulloblastoma, and epidermoid cyst. So these are the important sequences that we have. Then do remember this sagittal MRI of the knee and identify the ACL and PCL. Remember, they are based on the attachment on the tibia, not on the attachment on the femur. They are based on their attachment on the tibia. The PCL will usually appear like a question mark like area. Okay, so it will usually be like that. So this is ACL, PCL, and all these will be dark. Normal ACL, PCL, ligamentum patella, right? The ligamentum patella, the quadriceps tendon, all tendons, the supraspinatus tendon, the ligaments, the menisci, they normally are dark areas, both on T1 and T2. If you see white area, that means there is edema, there is injury to that area. So if you see something white here tomorrow in the image, right? So that indicates there is tear of the ACL. So normally they are dark areas. Okay, this is how we have the sagittal MRI of the knee. Okay, so we have finished two important chapters, CT scan and MRI. Now let's come to some important neuroimaging. This biconvex lemon shaped areas, right? So this is biconvex and lentiform, does not cross sutures, can cross midline, especially if it is in the frontal area. So imagine these are the frontoparietal sutures. If it is here, it can cross the midline, but will not cross the sutures. So epidural hematoma will be biconvex lentiform, right? It does not cross sutures, but can cross the midline. Whereas a subdural hematoma, the subdural hematoma will be Crescentric, concavo-convex. It can cross sutures, but here the fold of dura becomes falx cerebri, so it cannot cross the midline. So this subdural hematoma crosses sutures, right? It does not cross midline, does not cross midline. And remember, subdural hematoma, it is crescentric, concavo-convex. And this is a venous bleed. Among the bleeds that we have, this is a venous bleed occurring from bridging veins, right? So bridging veins. So it will take time to collect. So it's a bridging vein that is responsible for subdural hematoma. Whereas epidural hematoma is coming from middle meningeal artery, right? Fracture of pterion and trauma patients and all. Whereas subdural hematoma is occurring through bridging veins. So chronic old trauma will be subdural hematoma. And because this is bridging vein, so imagine this is the brain. We have a intracranial vein, extracranial vein, and there is a bridging vein here connecting them. So this is injured. So anytime you have boxer, right, and he is being hit and the head is moving in different direction, there is injury here and there is bleeding. Or there is a baby who is being shaken violently. So punch drunk syndrome that occurs in boxers, or you have a battered baby syndrome that occurs, or a shaken baby syndrome. What is the type of bleed that you see in these patients? It is nothing but subdural hematoma, because there is rupture of the bridging vein. So any kind of cortical atrophy also, if there is Alzheimer's in the patient, right, that also causes stretch over the bridging veins. So even in Alzheimer's disease, you have what is called as subdural hematoma, cortical atrophy, Alzheimer's disease. So remember these indications where we have subdural hematoma: the punch drunk syndrome, the battered baby or shaken baby syndrome, the non-accidental injury in the baby, as well as Alzheimer's. They can produce this subdural hematoma. It is crossing sutures, does not cross midline. Epidural hematoma does not cross sutures, but can cross midline. Okay, I hope this is clear. The next thing, can anybody tell me what is this sequence? Is it CT, T1, T2? Is it a CT scan, T1 weighted MRI, T2 weighted MRI, or is it a flare MRI? Can anybody tell me what is this sequence? Anybody can try that? Fast. Waiting for your answers. Very good. Anybody else can try? Very good. Serotonin, schizophrenia, med, ECG, cortical, right? So this is T2 weighted MRI. So the gray matter is white, the white matter is black, and the fluid is white. So this is T2 weighted MRI. Now, Haloverden-Spartz disease. This is a very favorite question of the examiner, Haloverden-Spartz disease. This is also called as pantothenate kinase associated neurodegeneration. So called as PCAN. Okay, PCAN. And this will have iron deposition in the globus pallidus. So whenever we have iron deposition in globus pallidus, iron will appear dark on MRI. Iron is black on MRI. So whether you have jet black liver, jet black spine, spleen, jet black vertebra, think of hemochromatosis. Iron is black on MRI. Black on MRI. So whenever you see this black deposits in the globus pallidus, remember when you have lentiform nucleus, the inner part is globus pallidus, the outer part is putamen, the inner part is globus pallidus. So when you see iron deposition in the globus pallidus, this gives the appearance of a eye of tiger. So tomorrow if you are given a question, eye of tiger appearance on MRI, or they are giving you the MRI image, please try to look at globus pallidus. Look at the black area in the globus pallidus. You will be able to pick up Haloverden-Spartz disease, also called as pantothenate kinase associated neurodegeneration. So please remember, when your MRI image is given and the option shows Haloverden-Spartz disease or eye of tiger appearance or PCAN, please go back to the image, try to look at globus pallidus. If you see black signal in the globus pallidus, that is iron deposition in the globus pallidus, that is Haloverden-Spartz disease. Now let us try to understand the next question here. Try to answer this question, guys, fastly. An elderly patient, hypertensive patient on treatment has dementia. He complains of clumsiness in movements of his right hand, especially while writing since past 2 weeks, and feeling of numbness, right? So difficulty writing, numbness on his right face, right upper limb, right? So there is a problem in the right hand. A CT scan is obtained and is shown below. So there is some weakness, clumsiness that has developed, some numbness that has developed, and there is a CT scan image that is given. What is the likely diagnosis? Is it hypertensive bleed, lacunar infarct, intraventricular bleed, or Parkinsonism? Can you tell me what is this? Anybody can identify? So if you can see here, the problem is on the right side. The patient is having symptoms on the right side. So the problem is on the left side. So in the left thalamic region, you can see here a small hypodense lesion. So this is what is called as a lacunar infarct. Remember, these are your, normal calcification. This is pineal calcification, choroid calcification. So these are normal calcifications. These normally gets calcified. Pineal gland, choroid plexus, they are normal sites of calcification. Do not get confused with that. These are normal sites of calcification. This small hypodense area, especially in the region of the basal ganglia, will be a lacunar infarct. And remember, the lacunar infarcts, they occur due to, lipohalinosis of lenticulostriate branches. Remember LLL, right? So these lacunar infarcts, they mainly occur because of the lipohalinosis of the lenticulostriate branches in the basal ganglia. So the small hypodense areas, those are your lacunar infarcts. Look at this next question. A 30-year-old male with sudden onset of high fever, headache, confusion and seizures. MRI shows hyperintensities in temporal lobes. What is the probable diagnosis? So here you are seeing a patient with fever, right? Some infected condition, and he's having involvement of the temporal lobe. Remember, the most common lobe involved in herpes encephalitis is the temporal lobe. Most commonly involves the temporal lobe, right? So temporal lobe is involved most commonly, right? Okay. Then let's look at the next question. Try to answer. I'll wait for your answers for this. A 2-year-old child with history of fever. So there is a 12-year-old child, history of fever. There is a chronic ear discharge and a head CT scan is obtained and given below. So you can see a head CT that is given. What is the likely diagnosis? Anybody tell me what is the thing? So this is a patient with fever, is having ear discharge and head CT is obtained. What is the likely diagnosis? Is it temporal abscess, cerebellar abscess, extradural abscess, meningitis in this patient? So it's simple, it's a temporal lobe abscess, okay? And remember, these would show diffusion restriction if you get MRI done. So diffusion restriction. So please remember, if you have a ring enhancing lesion, like how here it is enhancing like a ring. If you have a ring enhancing lesion showing diffusion restriction, right? It is a cerebral abscess, right? So it is a cerebral abscess. So based on the location, this is in the temporal lobe. So ear discharge, right? So ear discharge patient. So it will spread to the temporal lobe. So this is cerebral abscess. So remember, cerebral abscess is a ring enhancing lesion showing diffusion restriction. Now let's look at this next question. Try to answer this. There is a 35-year-old female with headache and MRI is given. What is the likely diagnosis? So can you help me with the diagnosis? What is the diagnosis here? Medulloblastoma, meningioma, ependymoma or hemangioma. What do you think is this? Very good, simple. This is meningioma. Remember, meningiomas are more common in female patients because of the hormone receptor positive. They are progesterone receptors positive. So these are hormone receptor positive. So more common in female. And you can see here, this is broad base towards dura. There is a attachment broad base towards dura. And you can see the adjacent dura is thickened. That is called as your dural tail sign. And you can see it is intensely enhancing. It is whitish, right? So that is called as mother-in-law sign. So you see the contrast which comes early enhancement and delayed washout. So your mother-in-law will be coming very early and going very late. Early to come and late to go. Right? So that is called as your mother-in-law. Dural tail sign is easy, right? Dura is meningeal layer. Dural tail sign is feature of meningioma, right? Broad base towards dura. Dural tail sign is feature of meningioma. Mother-in-law sign also is a contrast enhancement pattern. Because of this spoke wheel-like vasculature that you have, intense contrast enhancement will happen. Meninges are very vascular layer. So when you have a tumor there, spoke wheel vasculature is there actually here. So there will be spoke wheel vasculature, right? And that's the reason the contrast will come very fast there. You have intense contrast enhancement, early enhancement, and delayed washout called as mother-in-law sign. And you can see calcification, sarcoma body. Sometimes radiograph will be given showing a calcific area towards the broad base, towards the cerebral convexities. So sarcoma bodies are common in meningioma, right? So calcifications are common in meningioma. So these are important points about meningioma. Now look at this next question. There is a CT scan image and it is showing a solid cystic lesion with calcification in the cellular region. So cella is in front of the midbrain. So in the brainstem, so in front of the brainstem, you are seeing this calcific area. And the most common cause for supracellular calcification is a craniopharyngioma. So remember, craniopharyngioma differs from pituitary macroadenoma. So if you compare craniopharyngioma versus pituitary macroadenoma, if you compare this, craniopharyngioma is solid cystic. Remember, cystic areas are there. This is purely solid. This shows calcifications, right? No calcifications here, right? So if you see solid cystic area with calcifications, it is craniopharyngioma. Purely solid, no calcifications, that is a pituitary adenoma, right? And let us look at the next image here. Let us look at the next image. Try to answer this here. There is a 45-year-old female with visual symptoms undergoing MRI. So there is a 45-year-old female with visual symptoms and the MRI coronal and a sagittal image is given and you see a lesion there. What is the likely diagnosis? Craniopharyngioma, pituitary macroadenoma, pineal germinoma or meningioma? Can you please answer them? What is this lesion? So obviously this is what is called as figure of 8 appearance at cella. Figure of 8 appearance at cella. This is a pituitary macroadenoma. Pituitary macroadenoma. So you imagine this is the diaphragm cella. So when we have this pituitary macroadenoma, it grows, constricts and again grows back. So you have a constriction here, giving a figure of 8 appearance of the cella. This is pituitary macroadenoma, pituitary macroadenoma. And what visual symptoms do you expect when we have a pituitary macroadenoma? What is getting compressed? The optic chiasma is getting compressed. So what is the visual symptoms you have? What is the type of visual symptoms that you get when you have a compression of optic chiasma? Can you tell me what is that? Bitemporal, homonymous or heteronymous? Homonymous or heteronymous? Bitemporal. What kind of visual symptoms do you get when you have compression of the optic chiasma? Remember, in the image you saw, the optic chiasma was just above the pituitary gland. So whenever there is pituitary macroadenoma, obviously we will compress the optic chiasma and produces bitemporal heteronymous, right? Heteronymous hemianopia. Remember, it's the only place in the visual pathway which will produce this heteronymous. The problem in optic tract, optic radiation, visual cortex, all of them will produce homonymous hemianopia. The optic chiasma, right, will involvement of the optic chiasma will produce heteronymous hemianopia, bitemporal heteronymous hemianopia. Next thing, look at this next one. So if you are having given a skull radiograph and you are giving this image, this I hope all of you know, this is a classic hair on end appearance or crew cut appearance. Remember, whenever you are given this hair on end or crew cut appearance, the first answer should be thalassemia, right? So this should be thalassemia. The first answer should be thalassemia. If thalassemia is not there, it can be seen in severe hemolytic anemias like sickle cell anemias or any severe condition. So first answer should be thalassemia. If that is not there, then only go for severe hemolytic anemias, right? You can answer it here because you cannot see thalassemia, but thalassemia first answer. Next thing, look at this next question. A skull radiograph of a child with seizures and mental retardation is shown. What is the likely diagnosis? So if you see this skull radiograph, you see this lot of tram tract calcification, irregular vascular tram tract calcification is seen on the radiograph. And this is a child with seizures and mental retardation. You are seeing this tram tract calcification. This is classic Sturge-Weber syndrome. Sturge-Weber syndrome. What are the findings that you see in Sturge-Weber syndrome? Sturge-Weber syndrome is having port wine stain, you have hemiatrophy of brain, ipsilateral hemiatrophy, wherever the port wine stain, that side of the brain is atrophic. You have leptomeningeal vascular malformation. So please remember, Sturge-Weber syndrome is basically trigeminal-encephalic vascular malformation. In the trigeminal and in the encephalic region, you have a vascular malformation. So the other name of Sturge-Weber syndrome is trigeminal-encephalic vascular malformation. So these vascular malformation here will give you port wine stain. This is leptomeningeal vascular malformation. These irregular vessels will compress the brain, causing ipsilateral atrophy of the brain. And these irregular vessels will get calcified also, producing tram track calcification. And you'll have these pulsatile vessels producing seizures contralateral to the port wine stain. Atrophy will be ipsilateral to port wine stain. Seizures will be contralateral to port wine stain. So Sturge-Weber syndrome is nothing but trigeminal-encephalic vascular malformation. You have a port wine stain, you have leptomeningeal vascular malformation, hemiatrophy of brain, tram track calcification, seizures contralateral to port wine stain, atrophy ipsilateral to port wine stain. Okay, hemiatrophy of brain. This is Sturge-Weber syndrome. Now, let's look at the next one. A CT angiogram image is obtained of a child with high output cardiac failure. The following image is obtained. What is the likely diagnosis? So, you're having a child with cardiac failure and a CT scan showing a midline vascular swelling. So you have a brain showing a midline vascular swelling. So this is nothing but a vein of Galen malformation. Very good. Okay. Schizophrenia, serotonin. So please remember, vein of Galen malformation is a misnomer. Vein of Galen malformation is a misnomer. It is neither vein of Galen, it is neither a malformation. It is an AV fistula. There is no nidus, right? So it is a malformation will have nidus. A malformation would have nidus, right? So a true AV malformation will have nidus, but fistula will not have a nidus. And it is not the vein of Galen. It is actually a prominent. It is embryological precursor of it, a prominent median prosencephalic vein. Median prosencephalic vein. So please remember, vein of Galen malformation is a misnomer. You have three things. You have congestive heart failure, you have hydrocephalus, you have brain problem, you have heart problem, and you have a midline vascular swelling, giving that intracranial bruising. Okay. So intracranial bruising, the vascular noise on auscultation, you will be there. Right. So this is vein of Galen malformation. This is a classic triad of vein of Galen malformation. Congestive heart failure, you have a midline vascular swelling, you have hydrocephalus, right, because of this compression of the CSF flow, and there will be a intracranial bruising. Remember, it is misnomer. It is not vein of Galen. Okay. Please let me know, guys, if the audio is clear now. Yes? Can you hear me clearly now? Okay. So please let me know on this question, which arterial territory is involved on this CT scan image. So look at the CT scan, which arterial territory is involved on this CT scan image, and is it ACA, MCA, PCA, or posterior communicating artery. So look at the CT scan image, and if you look at the CT scan image, this is the ACA territory, right? This is the ACA territory. This is the MCA territory. This is the PCA territory. So you can see there is a wedge-shaped area involving the right MCA territory. So this is a complete right MCA infarction, right? So this is a right complete MCA infarction. Now look at this next question. Okay, there is a 65-year-old hypertensive patient on irregular medication of his hypertension, developed headache and a BP of 220/110. The CT head is obtained. What is the likely diagnosis? So you can see here, there is a hyperdense area. This is occurring in the region of the putamen, right? So this is putaminal bleed. Please remember the most common site of hypertensive bleed is putamen. And what is the reason for this hypertensive bleed? So what is responsible for this hypertensive bleed? Remember, the hypertensive bleed is occurring due to rupture of Charcot-Bouchard aneurysms, right? So rupture of Charcot-Bouchard aneurysms will lead to hypertensive bleeds. So identify the location, the putamen, as a common site for hypertensive bleed. Now look at this image. A 65-year-old female fall in the bathroom and sustained head injury. CT was performed, and what is the likely diagnosis? So image is given. What is the likely diagnosis? Can you tell me? What is this? Extradural hematoma, intracranial bleed, thrombosis, subdural hematoma. So this is a subdural hematoma. Please remember, acute bleed is hyperdense, is more white. So this is acute bleed. Chronic bleed is hypodense, that is dark. So you can see both things here. So this is an acute on chronic subdural hematoma. So there is both acute and chronic. And right side or left side? This is on the right side. So right acute on chronic subdural hematoma is given to you. Let's look at this next question. There is a CT scan image, and there is an acute onset of severe headache in this patient. A non-contrast CT is obtained. What is the diagnosis? Fast. Yes. Yes, serotonin is correct. This is subarachnoid hemorrhage. Please remember, severe headache, right, is nothing but the thunderclap headache, the worst headache of his life. Thunderclap headache. And remember the investigation of choice for acute subarachnoid hemorrhage. Because I told you, when you want to see anything white, you need to go for a non-contrast CT. And what is the most common cause for acute subarachnoid hemorrhage? What is the most common cause for acute subarachnoid hemorrhage? This is trauma. What is the most common cause for spontaneous subarachnoid hemorrhage? This is rupture of berry aneurysms, right? So, or saccular aneurysms. So, berry aneurysm or saccular aneurysm is responsible for a spontaneous SH, whereas trauma is the most common cause for this subarachnoid hemorrhage. And remember, it is the non-contrast CT that is done. Worst headache of his life, the thunderclap headache. Try to look at this next question. I hope you'll answer it correctly. RTA patient unconscious, CT scan is not showing any finding. Few petechial hemorrhages are seen. What is the likely diagnosis? I told you this thing. This is diffuse axonal injury. And what is the investigation of choice? This is MRI. The investigation of choice is MRI. Next. So let's look at review some neuroradiology after these questions. Let us look at the neuroradiology. So normal sites of calcification is important. The pineal gland, choroid plexus. These are normal sites. So this is the area of the pineal gland. This is the choroid plexus. Do not confuse it some bleed. These are normal sites of calcification. Where do you see periventricular calcifications like this? These are the ventricles, and just adjacent to the ventricles you can see calcification. Can you tell me where do you see periventricular calcifications? Periventricular calcifications are features of anybody? This is feature of CMV. Remember V for V. Periventricular calcifications is feature of CMV. Diffuse nodular calcification, especially at basal ganglia. This is feature of toxoplasmosis. Toxoplasmosis. And they're usually AIDS patients or, usually at basal ganglia. Where do you see subependymal calcifications? These subependymal calcifications, these are seen in tuberous sclerosis. Tuberous sclerosis. Right? These are also called as candle dribblings, right? So candle dribblings. And starry sky calcifications is feature of neurocysticercosis. So imagine this is the brain. These are the ventricles. Based on the location of the calcifications, are the calcifications periventricular? This is CMV. Or are they subependymal in the form of candle dribblings? This is tuberous sclerosis. Are they diffuse nodular at the level of basal ganglia? This is toxoplasmosis. Toxoplasma. And if there is scattered multiple like starry sky, this is neurocysticercosis. So periventricular is cytomegalovirus. Subependymal along the floor of the ventricle, the ependymal lining, is tuberous sclerosis, right? And diffuse nodular calcification, especially at the basal ganglia, is toxoplasmosis, and starry sky appearance is neurocysticercosis. You all know this is epiduolematoma, right? Biconvex lentiform, does not cross sutures. This is also epiduolematoma, but what is the difference here is you are seeing some hypodense black areas here. This is with a swirl sign. This is with a swirl sign. So when you have epiduolematoma with swirl sign, this swirl sign indicates active bleeding that is happening. Active bleeding. So basically, if I look at density, I told you CT scan is based on density of the tissue. So imagine this is iso, this is hypo, and this is hyperdense. When the blood is leaking out, or it is in the blood vessels, just hypo to isodense, okay. And as it becomes a clot, once it leaks out and becomes a clot, it becomes thick, it becomes denser, so it becomes hyperdense. And after the macrophages come and degrade it, it becomes hypodense. So acute bleed, once you have a clot, acute bleed will be hyperdense, more white. A chronic bleed, once the macrophages have degraded and liquefied it, it becomes less density. So chronic bleed is hypodense. And this is what is meant by the swirl sign, right? So there is active bleeding, just leaking out. So it indicates there is active bleeding and you need to do preferential craniotomy. You need to do a preferential craniotomy for these patients because there is active bleeding happening. There's still leaking happening. They'll be increasing in the size of the hematoma. There will be herniation of the brain, right? So early craniotomy, preferential craniotomy should be done. When you see multiple patients with head trauma, one having a swirl sign, take him for craniotomy first. That is the importance of swirl sign. Remember, acute bleed is hyperdense, chronic bleed is hypodense. A hypodense area, so within a epidural hematoma, is called as a swirl sign and it indicates active bleeding. Next, this is right subdural hematoma and it is hyperdense, so it is acute. And this we know this is acute on chronic subdural hematoma on the right side. So this is a chronic left subdural hematoma. You can see the hypodense area. And this is your subarachnoid hemorrhage, which shows hyperdensities in the sulcal spaces, right, in the sylvian fissures, basal cisterns, interhemispheric areas. So all these hyperdensities that you are seeing, this indicates subarachnoid hemorrhage. If you see hyperdensities in the ventricle, especially the occipital horns of lateral ventricle, this is intraventricular bleed. So this is how we have the intraventricular bleed. And this is the poorer prognosis, worst prognosis among the bleeds that we have. Indicate a lot of trauma to the brain. This is hypertensive bleed, right? Putaminal bleed, right? So this is putaminal, left putaminal bleed, right? So intraparenchymal bleed, the putaminal bleed. So I told you hemorrhagic strokes would be hyperdense, right? So hemorrhagic stroke will be hyperdense. So that is what I mean. So when you do a patient with hemiplegia comes to you, a cerebrovascular accident comes to you, you get a CT scan to know whether it is ischemic stroke or a hemorrhagic stroke. A hemorrhagic stroke would be hyperdense. A ischemic stroke, infarct, you saw the MCA infarct and all will be hypodense, right? So that is how we have. Remember, air will come on the top, fluid will come on the down. So fluid, the blood, right, will coming in the occipital horns of lateral ventricle, but air will go on to the top. This is called as Mount Fuji sign. This is feature of tension pneumocephalus. Tension pneumocephalus. This is a right MCA infarction, right? So the classic right MCA infarct, hypodense area. So infarcts, right, or ischemic strokes, they can be hypodense, that is black, or normal on CT scan. Sometimes it can be normal or it can show this hypodense area. So hemorrhagic strokes are hyperdense and ischemic strokes are hypodense on CT. So I told you the CT scan can be normal on strokes, and diffusion weighted imaging will be the most sensitive investigation to look at acute infarct for acute infarcts, right? And this is how you have a small lacunar infarct here, right? So this is lacunar infarct that we have. And sometimes the CT scan can be normal, but the only clue that you may have is a small vessel that is in the sylvian fissure. The vessel that passes in the sylvian fissure is the middle cerebral artery. So MCA will be traveling in the sylvian fissure. So in the sylvian fissure, you see this hyperdense area suggestive of a thrombus in the middle cerebral artery. So hyperdense MCA sign is an important sign of acute infarct. So like delta sign we saw in superior sagittal sinus thrombosis, in the same fashion when you have thrombus in the middle cerebral artery, that will become more dense, that will become more hyperdense. So hyperdense MCA sign is also a clue of acute infarction. So the entire CT scan may be, rest of the CT scan may be normal. The only clue you may have is a hyperdense MCA. You should think as a acute infarct, very important sign, right? Hyperdense MCA sign is a sign for acute infarct. Next. Please remember, this is flare MRI. You can see how to identify the flare. It is same as T2 with fluid suppression. And you can see this periventricular white matter hyperintensities involving the corpus callosum perpendicular to ventricles. These are your Dawson fingers, right? So flare MRI showing is the best sequence for multiple sclerosis. Right? It's best for multiple sclerosis and it shows Dawson fingers. Please identify the Dawson fingers. Then this is a vesicular stage of neurocysticercosis. You see a cyst with central scolex. You see a cyst with a central scolex inside. And here the parasite is alive. And you see minimal perilesional edema. So very small perilesional inflammatory edema will be there. So there will be very minimal edema. So there will be minimal edema in case of vesicular stage. The live parasite is there. But when there is, this starry sky appearance, this is suggestive of a calcific nodular stage of neurocysticercosis, and there will be no edema in this calcific nodular stage. So vesicular stage, there is a cyst with a central scolex. You have minimal edema around it. In calcific nodular stage, there is no edema. If they ask you no edema, the answer should be calcific nodular stage. Starry sky appearance also is calcific nodular stage, right? Next, can you tell me starry sky appearance? This you understood, calcific nodular stage. But on histopathology, do you remember starry sky appearance on histopathology? All of you should be knowing this. Can I ask you starry sky appearance on histopathology? Can you tell me histopathology? Very good. Jaw tumor, Burkitt's lymphoma, right? So Burkitt's lymphoma. Ultrasound liver, remember most of the liver becomes black, the portal vessels will be white, right, giving that starry sky appearance, the ballooning degeneration that happens, okay, ballooning of the hepatocytes that happens. So the ballooning of the hepatocytes makes that liver very black on ultrasound. So on ultrasound liver, this is acute hepatitis, okay, ballooning of hepatocytes. And on immunofluorescence, it is PSGN, post-streptococcal glomerulonephritis. So these are important starry sky appearances. Neurocysticercosis on CT brain, right? Burkitt's lymphoma on histopathology, ultrasound liver acute hepatitis, on immunofluorescence it is PSGN. And where do you see such conglomerate ring enhancing lesions? And on MR spectroscopy, they show lipid lactate peak. So lipid lactate peak is feature of tuberculoma, right? Matted lymph nodes, so conglomerate, matted lesions will be there, ring enhancing lesions. And coming to MR spectroscopy, remember at least three things. Lipid lactate peak that you have, lipid lactate peak, this is seen with tuberculomas, right? Any tuberculoma, toxoplasma, they can give, whenever you have this, anaerobic respiration happening, okay, necrosis happening, toxoplasmosis, tuberculoma, they can produce this lactate peak. And choline means lot of cell membranes, right? Phosphatidylcholine. So lot of cells are there. So this is tumors. So choline peak will be seen in tumors. Whereas N-acetyl aspartate peak, N-acetyl aspartate, NAA peak, right? So N-acetyl aspartate peak. This is seen in case of Kennewan's disease. Kennewan's. So remember, NAA peak is seen in Kennewan's disease. Kennewan's disease will have N-acetyl aspartate peak. So remember these three things. So whenever lipid lactate peak is thin, think of tuberculoma. Choline peak, think of tumors. And NAA peak, think of Kennewan's disease. And what is this ring enhancing lesion showing diffusion restriction? You can see a ring enhancing lesion and it is showing this bright signal on DWI, showing a diffusion restriction. Obviously, this will be cerebral abscess, right? So this will be cerebral abscess. And can you tell me, this is a fever patient and he is showing involvement of the temporal and basifrontal. So the most common encephalitis involving temporal lobe is your herpes encephalitis. And then can you tell me what encephalitis involves this thalami? Encephalitis involving the bilateral thalami is your Japanese encephalitis. Japanese encephalitis involves the thalami. And varicella, if you have chicken pox, right, varicella encephalitis, this will be involving the cerebellar hemispheres, right? So cerebellum will be involved in varicella encephalitis. So remember these encephalitis, right? So HSV encephalitis involves temporal lobe. This has been frequent question. We solved a question together also. So temporal lobe involvement is herpes simplex encephalitis. Japanese encephalitis involves the bilateral thalami. Cerebellum, right, is involved in case of varicella encephalitis. Next, coming to white cerebellum sign. So look at the rest of the brain. It is dark. Only the cerebellum is white. So this is called as white cerebellum sign. So whenever we have a poor perfusion to the brain, whenever we have hypoperfusion to the brain, the rest of the brain becomes hypodense, but cerebellum, because of its lot of collateral supply, you have a lot of blood vessels supplying the cerebellum, right? So ICA, PICA, superior cerebellar artery, and a lot of collateral supply. So it will escape the salt. So this will produce what is called as white cerebellum sign. It is a feature of an irreversible brain hypoxia. It's irreversible brain hypoxia. Any cause of hypoperfusion, right, that causes the brain to become hypodense, and it is poor prognosis, right? It indicates poor prognosis. Coming to the next, swallowtail sign. So the swallowtail sign is a normal appearance of the substantia nigra. You know the midbrain, it has the tectum, tegmentum, the substantia nigra. So the substantia nigra will be bifid like this. The black color substantia nigra will be bifid. This normal appearance of substantia nigra, because of the presence of this nigrosome 1 protein, will give that black color appearance. Okay, so this is swallowtail appearance. If you have degeneration of substantia nigra, that is called as Parkinsonism. So that will show you an absent swallowtail sign. So swallowtail sign is normal appearance, bifid appearance of substantia nigra. And whenever you have lack of substantia nigra, degeneration of substantia nigra, that will be seen with Parkinsonism. Next, remember, in progressive supranuclear palsy, when we have a patient with progressive supranuclear palsy, this is a condition where we have midbrain atrophy. So when we have midbrain atrophy, on a sagittal MRI, I told you how to look at the brainstem, right? Pons, medulla. So when there is midbrain atrophy, the midbrain becomes much smaller. And then you have the mammillary body anteriorly. It gives this is the fourth ventricle and the cerebellum. This gives the hummingbird sign. And your Mickey Mouse sign, you have a rounded appearance of the cerebral peduncles. So there will be rounded appearance of the midbrain, giving a Mickey Mouse appearance on an axial MRI. So Mickey Mouse appearance on an axial MRI, and this hummingbird sign on a sagittal MRI brain is suggestive of progressive supranuclear palsy. So progressive supranuclear palsy is a condition which is associated with midbrain atrophy. So it will produce what is called as, hummingbird sign on sagittal MRI and a Mickey Mouse appearance on a axial MRI. Remember, copper is white on MRI. I told you iron is dark on MRI, copper is white on MRI. Iron is dark on MRI. Iron in the liver, black spleen, black vertebra, right? So think of, iron deposition, iron overload. Whereas copper is white. So when you have copper deposition in the midbrain, right, sparing the red nucleus. Except on the red nucleus, rest of the midbrain will have copper, and that gives the appearance of a panda sign. So panda sign is seen in Wilson's disease. Wilson's disease. Molar tooth sign is feature of Joubert syndrome. Joubert syndrome is a condition where we have vermis hypoplasia. So when we have vermis hypoplasia, the superior cerebellar peduncles will elongate. So the elongated superior cerebellar peduncles will make the appearance of the midbrain along with the interpeduncular fossa, give the appearance of a molar tooth. So molar tooth sign is feature of Joubert syndrome. And because the vermis is hypoplastic and the superior cerebellar peduncles are elongated, the shape of fourth ventricle also appears like a bat wing. So bat wing fourth ventricle will also be seen in case of Joubert syndrome. So remember these two things. Vermis hypoplasia is seen with Joubert syndrome. So because of the vermis hypoplasia, right, the CSF signal will increase posteriorly. You have elongated cerebellar peduncles giving that molar tooth appearance and a bat wing fourth ventricle in Joubert syndrome. Next. Please look at this, guys. Can you tell me in which condition do you get these gyral hyperintensities? Like this gyral hyperintensity is called as cortical ribboning. The cortex, the gyri, or they form the cortex, right? So they are appearing very hyperintense, cortical ribboning, and even the basal ganglia are involved. So a patient having this cortical ribboning and gyral hyperintensities, this is nothing but CJD, Creutzfeldt-Jakob disease, Creutzfeldt-Jakob disease, right? And a variant of CJD will involve the medial and posterior part of the thalamus. You know, on either side of the third ventricle, we have thalamus. So there is a variance of CJD which involves the medial and posterior thalamus, and that produces a hockey stick sign. So hockey stick sign is feature of variant CJD, whereas cortical ribboning is feature of CJD. Remember, molar tooth sign Joubert syndrome, panda sign on MRI brain is Wilson's disease. Okay, copper deposition, Wilson's disease. And Mickey Mouse appearance and hummingbird appearance is feature of progressive supranuclear palsy. And I hope swallowtail sign is normal appearance. Absent swallowtail sign is feature of Parkinsonism. White cerebellum indicates irreversible brain hypoxia, right? Any cause of hypoperfusion to the brain, irreversible brain hypoxia produces white cerebellum sign. The cerebellum will be white, rest of the brain will be hypodense, a poor prognostic finding. Next, if you have involvement of bilateral corticospinal tracts are involved, right? So you can see the bilateral corticospinal tracts are involved. Obviously, corticospinal tracts are motor tracts. So you have a motor neuron disease, that is amyotropic lateral sclerosis. And because there is bilateral corticospinal tract involvement, this is also involved, this is also involved, there is bilateral corticospinal tract involvement, it gives the appearance of a wine glass. So wine glass appearance on MRI. Wine glass appearance on MRI brain. This is feature of nothing but amyotropic lateral sclerosis. Remember, bilateral corticospinal tract involvement is ALS. Coming to the next angiography image, look at here. This is puff of smoke appearance, puff of smoke. And this puff of smoke appearance is an angiography finding that you see in Moyamoya disease. In Moyamoya disease, there is a vasospasm, chronic vasospasm of the ICA. There is a chronic vasospasm of the supraclinoid part of ICA, the internal carotid artery. And in the pre-stenotic and post-stenotic area, a lot of collaterals will crop out to maintain the blood supply between, right? So because a lot of collaterals come out, they give this puff of smoke appearance. So whenever there is to have collaterals, you need to have chronic vasospasm. It won't occur in acute vasospasm, right? So collaterals will develop in chronic vasospasm. So a chronic vasospasm of the upper part of ICA leading to this puff of smoke appearance. This is feature of Moyamoya disease. Next. Vein of Galen malformation, we learnt, right? I taught you already about vein of Galen malformation, triad of hydrocephalus, vascular swelling and congestive heart failure. Remember, it is an AV fistula and it is a prominent median prosencephalic vein, not a vein of Galen. Hot cross bun sign on MRI brain. Hot cross bun sign, please remember this one-liner will be asked also. Hot cross bun sign on MRI brain is suggestive of multi-system atrophy type C, MSA type C, multi-system atrophy type C. So basically, this is the basilar artery. So this is pons. So to identify pons, we need to look at this basilar artery. So in the pons, you are seeing the pontocerebellar fibers will become hyperintense. So the pontocerebellar fibers will appear hyperintense, giving the bun-like appearance, right? We have for breakfast that bun. So hot cross bun, you have this cross over it. Hot cross bun sign is feature of multi-system atrophy type C. So I hope this is all clear for you guys. We'll take a break here and we'll resume in the next session. Okay, so the next session is also planned. So we have tried to cover CT, MRI and a lot of neuro also, and I'll also come back again and I will reschedule the session again. Okay, are you guys comfortable so far? All the important neuroradiology science we have completed, and we'll come back in the next session. Okay, the part 3 of it. Just let me know if you're comfortable and you're able to follow what we are discussing, right? Can you just, okay, message if you can, hear me properly. You guys are comfortable with whatever we've discussed so far, right? Chalo, we'll just meet up in the next session. Okay, so it's planned at 10 o'clock. I'll try to catch up at 10 o'clock with you guys. Okay, take care. Thank you.